memory efficient implicit training strategy for a neural network immune for real-time cardiac MR reconstruction. From Northwestern University and GE, and it's Nicolas Yakovlev that's going to present.
Thank you for the introduction. So I'm going to be presenting on behalf of Nikolai, who was not able to make it because of visa reasons, but all of the work that I'm presenting is really done by him, so I'll do my best to do justice and try to faithfully represent his work. But if you have any detailed questions, please do email him. He's happy to answer your questions and so on. Okay, so the obviously for image reconstruction, deep learning networks have been applied extensively, and it's getting more and more popular because, as you guys all know, any type of iterative reconstruction is slow. So if you want to do inline reconstruction, you really need to move away from iterative reconstruction and move to deep learning. Now, amongst the different things that you can try is the unrolled network's been gaining a lot of attention lately, and one of the reasons being is because it's more interpretable, and including for image reconstruction. So traditionally, if you had sort of an infinitely depth sort of architecture, perhaps you could map from input to output because you're trying to solve a complex inverse problem, but the memory requirement and the amount of the training data that's required is just very not feasible. So people have been unrolling it, and then the nice thing about that is that you could start to incorporate sort of a physics-based constraints such as data fidelity, or maybe perhaps you want to take it into another transform domain. So you have all these options, but the downside is that each time you start adding these little modules, then the memory requirement is going to scale. So those are the sort of the trade-off that you have to consider. In the context of multi-dimensional MRI data, this becomes a problem because you're talking about multi-coil, you're talking about multiple dimensions, time dimension, and so on and so on. And on top of that, if you wanted to do non-Cartesian stuff, you have to incorporate NUFFT, which is also very slow. So these are some of the constraints. So the end-to-end training of unrolled networks becomes very challenging for multi-dimensional dynamic MRI. So we tried to solve this using the implicit networks, which is basically, another term would be deep equilibrium networks, that are basically a new class of models that moves away from traditional depth in favor of finding a fixed point of a non-linear layer. So unfortunately, that part is still considered a black box. So just to demonstrate, instead of trying to map from the, again, input to the output, and you might require a really, really deep layer to do so, the idea is to sort of implicitly learn by looping this iteratively so that you could sort of arrive at the infinite depth level. And this has been shown to be very competitive with the state-of-the-art deep learning networks. And the nice thing is that it requires significantly less memory and to arrive at the infinite depth solution. But the downside is that it is slower, and then it can be very sensitive to the architecture that you choose, and it can be unstable. And then again, just the fixed point part is another black box. So even though you want it to be more interpretable, you introduce another black box. And then also, it doesn't come for free, so it often requires a very computationally costly Jacobian-based gradient to calculate the gradients. That slows it down, but there's a solution. So recently, Feng et al. In 2022 proposed a Jacobian-free backpropagation. So, and the idea, as shown here, is that you could basically backpropagate only the last layer to arrive at an approximate solution. So that's what we did. So the purpose of our study is to develop a strategy to unroll networks for multi-coil real-time SynMRI as an implicit network to drastically reduce the computational demand. And this, although we tested it for SynMRI obtained using radial case-based sampling, we do believe that this idea can be extended to other multi-dimensional MRI data sets. So these are the parameters and the data set that we work with. So the obtained a multi-coil real-time cardiac synonym data set obtained using a radial case-based sampling from 40 patients with the mean age about 68. So we purposely split the data into dominating the testing data set because we wanted to demonstrate that this network is fairly robust even with the smaller size training data set. So we made the ratio tilted toward more for testing. And then we used GRASP or radial compressed sensing as the gold standard and these other pulse sequence imaging parameters. So here is our architecture. So we chose to layer a 4 depth, and we basically have a data fidelity term here, as well as we have the complex UNet as a regularizer. And then again, using the implicit theorem, what we did was we basically backpropagate only the last layer, and then we use L2 plus perceptual loss for the loss term. And then we compared our network with the conventional complex UNet, which is obviously purely data-driven. But we don't expect this to do well, obviously. And then we also compared against the alternative unrolled network that the PTB group has proposed recently. And this could be stated as a, one of the best unrolled networks out there. And then what they did was they cascaded the data consistency and the regularizer blocks. And this was actually specifically tested for non-Cartesian radial Sine data, I believe. So we did that. So here are our results. So on the left is the ground truth using GRASP or compressed sensing. And then the second column is if you did zero field NUFFT. As you can see, you're going to get crappy results. And then the third column is the complex UNet. And you can see that the results are pretty decent, but you get some residual streaking artifact that the simple complex UNet cannot resolve. The PTB group's alternative unrolling network, it does a very good job. And then our network immune, it basically does the same. But then maybe perhaps the error is slightly less, but nonetheless, they're very comparable. Now, summarizing the results over those number of Sine data sets that we tested. So for the SSIM and the normalized RMSE and PSNR, actually immune did the best. The blur metric between alternative UN and then the immune were about the same, so it's a push. But if you look at the training time, our immune was, took less than the alternative UN because again, if you unroll it, it just becomes more and more complex. The standard UNet obviously was the shortest. So this sort of training time, obviously you could, that's a lot of carbon footprint, right, that we were worried about. The inference time for 40 frames per Sine set, as shown on the bottom. So obviously the complex UNet was the fastest because you don't do any NUFFT. The PTB's groups there took about 10 seconds, but for us it's about a little bit less than 2 seconds. So in conclusion, our strategy was pretty successful for applying unrolled networks to non-Cartesian real-time Sine MRI. It is an efficient strategy to do the training where we were able to minimize, to address and manage the memory requirement to conduct such a strategy. And it performed better than the CUNet in terms of performance. In terms of speed, it was better than the PTB group's alternative unrolled network. And with that, I would like to thank my colleagues and especially my trainees who did all the work and my funding sources. Thank you for your attention.
Thank you very much. Is there any question? So I have a question. What would be the time of reconstruction for a full heart Sine acquisition?
What do you mean by full heart?
So the overall volume.
So this was, like I said, single slice, about 40 frames. It took about 1.5 seconds. So you just multiply by the number of slices that you want to obtain.
So it's less than 20 seconds altogether?
Yes. Yep.
Okay. Yep. And it runs on, so you don't need to have dedicated hardware.
This is on a GPU hardware. This is on a GPU hardware.
Okay.
But we could run it obviously on the CPU mode because the training is what requires to be on the GPU. But if we ran it on the CPU, it'll be slower, but it won't be less than 2 seconds for sure.
Okay. Okay, so let's move on to the next lecture. Thank you.
All right, and the next presentation will be given by Dr. Anthony Christodoulou, who will present alternating low-rank tensor reconstruction for improved precision and repeatability in cardiovascular MR multitasking.
All right, thank you very much. This work was done by Dr. Tianle Cao. I'm presenting on his behalf because he couldn't make it. I have nothing relevant to disclose. So we saw in the talk yesterday morning from Professor Sakuma the importance of quantitative CMR. But I want to talk about the key technical needs that we would use for quantitative CMR, which is really that we need precision and repeatability in order for this to be reliable for diagnosis. So we have been working for many years on the MR multitasking framework, which is a non-ECG free breathing approach to quantitative CMR. It's a multidimensional framework, so we take all of these overlapping dynamics, relaxation and motion, and we model them as different time dimensions. And then we use a low-rank tensor decomposition to decompose the image array. And what that does is we create essentially a basis function model for each individual dimension. So the way that we have been calculating this in terms of image reconstruction is something that we call fixed subspace reconstruction. And this is something that is very convenient for memory usage and computation. But there's a little bit of a catch, which is that different bases are calculated from different subsets of our data. So what I mean by that is we have our models that we build for relaxation. Those come from SVD analysis of a dictionary. But then we actually have the patient-specific bases. So these are the temporal bases for motion, for example. And we calculate those from a subset of data which don't have a lot of spatial information, but are highly temporally resolved. So that's our NAV data. And then the remainder of our acquired data has more extended K-space coverage, more spatial information, and we use that to actually then recover our image model, essentially. We put all these together, and we can create our multidimensional image. So the limitations of this strategy are that none of those reconstruction steps actually leverage the whole set of data together. Each subset of data is used to individually reconstruct different bases. And we also know from prior work that the temporal bases, particularly for motion in this case, from a NAV data subset, likely are suboptimal for the image as a whole. So Tianle's work was to improve the precision of MR multitasking and repeatability, since those are two very important things, as I mentioned, in quantitative CMR. And his approach was to more efficiently actually use the data that we collected. And he specifically came up with a way to jointly estimate both the temporal and spatial bases from the entire data set together. So what this looks like is we still use the physics model for the T1, T2 dictionary. We trust that, but all the remaining factors, spatial information, motion information, are really reconstructed from the entire data set that we've collected. And so he developed this cost function, and we don't have time to go through it, but the key points here are that what he did not sacrifice the memory usage, which is of course a big challenge in multidimensional imaging and the reason why we use a low-rank tensor in the first place, and also that this is one cost function that uses the entire acquired data. So the first step was to do some numerical simulations. So he used the XCAT Phantom with 20 cardiac phases and 6 respiratory phases, some heart rate variability, some respiratory variability, and then simulated the sequence that we use in practice for T1, T2 mapping. These are the results of the simulation. So the middle row with the blue bar is the fixed basis, essentially the old way of reconstruction, and the orange bar on bottom is the joint update, so this is the new reconstruction. And sure enough, the root mean square error of the image went from, I don't know if you can see my cursor here, I guess not, went from almost 100 milliseconds to almost 60 milliseconds, and then a little bit of T2 as well improvement. So we also looked at different scan times. So this is essentially the same thing, the root mean squared error, but now at different simulated scan times. And sure enough, we can see that for T1 and for T2, the new reconstruction approach essentially cut down the reconstruction error at all of these scan times. And this horizontal bar shows that essentially if you look at the level of error, what we were getting with the fixed basis reconstruction at 90 seconds is quite similar error to what we get with the new reconstruction at 50 seconds. And that held for T2 as well. But we are interested specifically in precision, so the next thing Tenla did was to actually split this out. RMSE is a combination of both bias and precision. So were we improving bias or were we improving precision? And found out that actually there's not a whole lot of change in bias. We're not changing mean values when we do the reconstruction. Essentially, all of this improvement does come from precision for both T1 and T2. So we then moved on to an in vivo study in 20 subjects. That's 10 healthy volunteers and 10 cardiomyopathy patients, running the same sequence that we had simulated before. And the total scan duration was 90 seconds, but then based on what we'd seen in the simulation, we also truncated the data to the first 50 seconds so that we could compare the two scan times. And each subject got this twice as well so that we could properly assess repeatability. He evaluated the precision based on the intra-segment standard deviation in the healthy volunteers, where we don't expect a whole lot of heterogeneity in the values, and then repeatability by looking at the change within each segment between two scans for both the healthy volunteers and the patients. So here's an example. I don't know if you can appreciate it on the screen, but essentially for T1 and T2, you can see that there's an improvement in SNR. And this is true in the second repeat as well. And then when we shorten the scan time, we see essentially the same thing. And actually, in this case, also, we found that there was quite poor image quality in the second repeat of the shorter scan in T1. If you can appreciate that, on the inferolateral segment of the T1. And that was improved by the joint update reconstruction procedure. This is an example in a cardiomyopathy patient. Again, this is quite a lot here, but what I hope you can appreciate in this, the T1 at the base is that the shorter scan for the fixed basis reconstruction, the old way of doing the reconstruction, actually is a false positive of some elevated T1 in the anteroseptal segment that was actually fixed by the joint update and corresponded better with both the standard ECG-triggered breath-held sequences as well as the LGE. So actually comparing across all the scan times and reconstruction procedures, essentially what we found was that sure enough, in every case, the joint update had better precision than the fixed basis reconstruction and even retained its precision improvement even when you still cut down the scan time, at least for T1. And at T2, cutting down the scan time actually had then the same precision as the old reconstruction in a long scan. And we saw the same things for repeatability. Essentially, joint update was always better, more repeatable, and was not significantly different from the longer scan and the old reconstruction. So in conclusion, Tianle developed a novel approach for lowering tensor reconstruction that alternatively solves the spatial and temporal components from the entire acquired data. It improved T1 and T2 precision and repeatability, showed promise for potentially trading that for shorter scan time, may have an impact on diagnostic accuracy. And just as an example, put this up here particularly as we saw yesterday, Dr. Sukuma talked about guidelines for amyloidosis. The level of T1 repeatability improvement that we actually got, actually before, we probably could not have reliably diagnosed or monitored amyloidosis, but now that improvement is now within the range of published differences. Thank you very much.
Thank you, Anthony, for a great talk. Are there any questions from the audience? Well, if not, I have a question. It's really interesting work, how you can kind of decompose these various aspects of the scan. I was wondering, and I may have missed it, how long does it take to reconstruct your data and get those nice quantitative maps that you showed?
The specific time, probably have to ask Tenma. I believe at this point it's on the order of half an hour to do it the old way. And the cost that we do pay for this, for the additional precision, is that it extends by about a factor of 2.
Oh, okay.
So it's still a challenge for us to solve.
Great, great. Thanks very much. Yeah, we'll move on to the next speaker. Will be
Accelerated free breathing 3D cardiac T1 mapping pulse sequence with XD graphs reconstruction from Penn State.
Hi everyone, I'm Suvai, actually from Northwestern, but we collaborate with Walter Witchy at UPenn. Excited to talk to you today about our 3D T1-row mapping. So as we know, extracellular volume fraction and late gadolinium enhancement are the gold standard methods for fibrosis quantification in the myocardium. Unfortunately, they have some limitations, such as the requirement of gadolinium, which, as we've discussed during this conference, is not ideal, particularly in pediatric patients. Additionally, the clinical standards that we use require breath holding and have an insufficient resolution. To attack the gadolinium aspect, T1-row mapping is a promising non-contrast technique that has gained a lot of popularity in the past few years. It has been shown to potentially be able to detect both focal and diffuse fibrosis in the heart. So just a little background on what is T1-row. Traditionally, without any T1-row spin locking, after a 90-degree tip pulse, we get normal T1 and T2 or T2 star relaxation. However, with T1-row spin locking, after a 90-degree tip down, we apply a spin locking continuous pulse to reach a steady state. And basically, you're tipping the be effective at an angle. From this, we get T1-row, which falls in between T1 and T2. So while T1 reflects exchange rates at the order of kilohertz to megahertz, T1-row characterizes the lattice at a few hundred hertz. And how this relates to fibrosis is that T1 tends to measure these faster moving molecules, which traditionally is water, whereas T1-row could measure these bigger macromolecules of proteins such as collagen, which could lead us to understanding fibrosis. So the current limitations with T1-row imaging are poor spatial resolution and long scan time of up to 18 minutes. And therefore, our goal was to develop an accelerated, free-breathing, high-resolution, 3D cardiac T1-row mapping sequence. For our pulse sequence, we applied a saturation recovery prep pulse after every heartbeat to ensure that we are always starting our magnetization at the same point. Our T1-row prep included a 90 tip down, spin locking, a 180 refocus, another spin lock, and then a 90 tip up. We acquired self-navigating rays before our GRE readout for self-navigation, and this sequence was done 3 times with 3 different spin locking times of 0, 35, and 50 milliseconds. Our data was acquired in a stack of stars K-space sampling scheme in a center approach where every heartbeat we alternated the direction of K-space sampling. In addition, within each 3D stack, we rotated the angle of the acquisition by tiny golden angle, and within each heartbeat, rotated by golden angle. We use an XD graph reconstruction pipeline where we get our raw data, bin it into 6 respiratory bins based on our self-navigation signal, and using enough and coil sensitivity information can do our CS recon. So we were able to scan this in 12 patients and achieve a 9.5-fold accelerated 3D T1-row. These are some of the parameters that we achieved with a spatial resolution of 2 millimeters isotropic and an overall scan time of around 6.5 minutes. The 12 patients that we added the scan onto were patients undergoing a clinically indicated MRI, so we were able to get native T1, post-contrast T1, and LG maps as well. So here's an example of our 3D T1-Rho image quality. When we collect our data, we scan the patient in a coronal plane, and as you can see here, we can then reformat the 3D volume into a short axis stack, and because of the isotropic resolution, we're able to easily do that with no partial volume averaging. You can see in the top 3 rows, we have the spin locking times of 0, 35, and 50 milliseconds. And then using these 3 data points, we can use least squares fitting to quantify the T1-Rho map, as you can see on the bottom. So then in each patient, we have our T1-Rho map, and then we also have the clinical images, the native T1 map, post-contrast T1 map, and LGE. And so based on the LGE images as well as the clinical reports, we can go through and find those areas of enhancement and where focal scar is located. And so then we're able to draw an ROI on that scar region, as well as an ROI on the scar-free region to quantify T1-Rho values. So this was performed on all 12 patients at the base, mid, and apex based on the location of the native and post-contrast T1 maps, since those maps were only performed at certain locations within the heart. And of the 12 patients that we scanned, 11 had focal scar on their LGE exam. So when we try to look at correlations between T1-Rho and ECV and T1-Rho and native T1, as you can see, there is no clear correlation that we can pick up from the data at this point. However, we think that the T1-Rho could be affected by many factors, such as the type of disease, is it ischemic or non-ischemic, the duration that the patient has had this cardiomyopathy, and so our goal is to look more deeply into this data to see if there's something else we can tease out from this information. However, by looking at our T1-Rho and comparing fibrosis versus non-fibrosis, we can see that we do see significant differences in areas without fibrosis and those with fibrosis. So the no fibrosis areas were ECVs less than 30 and no scar detected. Diffuse fibrosis was ECV greater than 30, and then focal fibrosis was LGE enhancement as determined by the clinical report. And as you can see here, the areas with no fibrosis had an average T1-Rho of around 57 milliseconds, whereas those with fibrosis had an average T1-Rho around 67 milliseconds. As you can see here, the focal fibrosis has a much wider range of T1-Rho values, which again is something interesting that we need to look more deeply into and understand what's happening. So with that, to conclude, we achieved a 9.5-fold accelerated 3D T1-Rho with a 2 millimeter isotropic spatial resolution and around 6.5-minute scan time. We were able to achieve good image quality and T1-Rho values that match similar to previously published values. And our 3D T1-Rho could be used for detecting focal and diffuse fibrosis in the myocardium. So moving forward, we want to collect more data and also try to look more closely at all that T1-Rho information to better understand the differences that we see. With that, I want to thank everyone at Northwestern, particularly the members of the Dan Kim Lab, and I'm happy to answer any questions.
Thank you. Sorry for the mistake from the university. Is there any question?
Thank you very much for this nice presentation. I think this is really important work. I was a little bit surprised by your correlations you showed, and I was wondering whether one contributing factor could be, I mean, your reference standard is a 2D acquisition with a relatively thick slice, and you compare it through a 3D acquisition where you kind of have to co-register on the one hand and think about the slice thickness you reconstruct on the other hand. May this perhaps be a contributing factor?
Yeah, that's an excellent point. As Dr. Suber mentioned, these are very different. We can't compare them exactly the same, so I think we need to look more closely at that and see if maybe that is a contributing factor. Thank you. Yeah.
Thank you for your
Yeah.
nice presentation. I was wondering what method did you use for fitting them up?
For what, Emma?
For the fitting?
Oh, fitting. We do least squares fitting, sorry.
Okay, and
Yeah.
do you use exponential fitting or?
Yes, an
Okay.
exponential fitting,
Okay,
yes.
thank you very much.
Mhm.
Thank you.
Thank you.
Okay, the next presentation will be given by Dr. Robert Edelman, who will present caipirinha and accelerated 3D unbalanced steady-state free precession for full volume dark blood MR angiography of the chest.
Thank you very much. So dark blood imaging is routinely used for MR of the heart. We acquire one or maybe a few slices using a two-dimensional turbospin-echo sequence. The T1 space sequence that we saw earlier this morning, which is so powerful for imaging of the carotids and intracranial circulation, just does not work well in the chest. So we're quite limited in our ability to use dark blood imaging. So we have been exploring a very different approach based on 3D unbalanced steady-state free precession techniques. And the overall goal of this presentation is to see if we can do 3D imaging of the entire chest in a single breath hold. So we're all familiar with the balanced steady-state free precession techniques, such as true FISPs, which work very well for cine imaging of the chest. And in fact, as a cardiac imager, you'll know that we use that for scout imaging as well. But this sequence suffers from off-resonance effects and also a lack of adequate contrast outside of the cine application. Now, unbalanced techniques, such as the FISP or PSIF technique, are not used clinically at all, for the most part. However, these are insensitive to off-resonance effects. And so we have been exploring the use of these. One is an ECG-gated unbalanced FID version or FISP type version, which is unbalanced in both the slice and readout directions. And we previously described that for dark blood imaging of the aorta, lungs, and mediastinum. And then a PSIF version, which produces a spin echo rather than FID. And we found this is less sensitive to motion than the FISP version. And I'll show some examples of this. So before we get into the CAPI aspect of this, let me just show you some examples because most people have not seen this before. This is a standard vibe sequence which is used in most parts of the body for 3D imaging, and there is a lung nodule that can be seen here. However, as you can see, there's a lot of structures that look gray or bright, and it makes it difficult to separate the lung nodule from other tissues. However, using this 3D unbalanced steady-state sequence, any moving blood appears dark, and therefore the lung nodule becomes very easy to see, and we see excellent contrast here. And you'll also notice there's absolutely no off-resonance effects apparent, unlike a true FISP type sequence. Here's just another example. This is a true FISP sequence. You can see the off-resonance effects in the chest wall. Very hard to see any lesions here. However, when we go to the unbalanced sequence, we can see multiple lung nodules very nicely seen comparably to a CAT scan. Just another example. This is, again, a true FISP sequence, which is very good when you're doing dynamic imaging, but when you just do a scout where you lack the time resolution, very hard to distinguish the blood gray or bright blood signal in the veins and aorta here from the cyst, which is shown by the red star. And this is just an example of a tumor where we see the tumor on the 3D vibe sequence, but really not very good contrast because these are not ECG-gated sequences and everything kind of appears gray. This is the unbalanced sequence showing the tumor very nicely, and this is the corresponding CTA. And this is just a comparison between the FID version showing the tumor and the CIF version, which is much better for showing cardiac anatomy. So, what are the limitations of this? One is that we use a 1D GRAPPA acceleration with an acceleration factor of 2 or 3 along the phase encoding direction, which reduces the echo train length, but it doesn't reduce the scan time because we acquire 1 slice for each RR interval. So the breath hold time is inversely proportional to the heart rate. Consequently, we're limited in the number of slices that we can acquire, especially in patients with slow heart rates, and this requires several breath holds to image the entire lungs. So we hypothesize that using a Kayper-Hina 2D acceleration would make it possible to scan the entire lungs in a single breath hold. So Kayper-Hina is the Brazilian national drink. For some reason, Mark Griswold has named all his acceleration techniques after alcoholic beverages, and it's kind of amusing, but it does allow the use of higher acceleration factors by reducing aliasing artifacts and improved signal noise compared with the standard approaches. So most of you are probably familiar with this, but if this is a fully sampled K-space, this is 1D acceleration where we leave out every other line, and we see the ghosting artifacts that are corrected in the reconstruction process, and KP offsets these data points with a phase shift, and it behaves much better for the reconstruction purposes. However, if you try to do this with the standard true FISP type sequence, it becomes very challenging to avoid artifacts because the true FISP sequence is sensitive to any phase variations. And so here's a comparison of a 3D true FISP in a phantom, and this is with an 8-fold acceleration. We see quite severe artifacts. However, if you use an unbalanced sequence, the artifacts are mostly absent. So let's look at some in vivo results. This is a breath hold unbalanced SSFP sequence, and you can see how much coverage you can get in a single breath hold is rather limited. And here with the KP acceleration, we can go much better. Here are some other examples. This is 1D acceleration, this is 2x2 acceleration, and this is 2x3 acceleration, where we can actually use a non-selective excitation covering the entire area. Here's a comparison between the GRAPPA 1D acceleration and the KP 2x2 acceleration, and this is the CIF version where you can actually see the heart quite nicely as well. And this is just a comparison of 2D true FISP versus the KP. Let me just skip through this. This was just a nice case. This is a cardiac case where there was a lesion that was not seen on the scout images, but when we ran the KP accelerated unbalanced SSFP, we can see this large spiculated lesion, and this was proven to be a lung cancer, early stage lung cancer. So in conclusion, 3D unbalanced steady state free precession with Kayper-Hina acceleration improves spatial coverage compared with 1D acceleration. You can also use it to reduce scan time, shows only mild image artifacts, and allows whole chest imaging in a single breath hold. Thanks very much.
Thank you, Dr. Edelman, for a great presentation. This talk is open for questions from the audience.
Thanks, Bob. Nice images. I'm just interested if you could comment on what these might look like with GAD contrast on board, if we're looking for enhancement of myocardium maybe, or the vascular wall, the thoracic aortic wall.
Yes, so that's actually a very good application. This is an offshoot of a brain imaging technique, what we call UTRES, which is exactly what you're asking about, a T1 weighted version with a saturation recovery. And so we have a lot of experience with that in the brain. It's excellent for detecting gadolinium contrast. We have some experience with it for vascular imaging, and it does work very nicely for that as well. Hopefully that will be for future studies. But it does work well. You get no artifacts, and you can suppress the blood flow and make the enhancing tissue appear bright.
Very nice talk and very impressive images. I have a quick question regarding this technique in general. Is, if I understand correctly, the dark blood effect is actually based on the dephasing of the moving spines. And in other words, some tissue that is moving, for example, has myocardium, could also basically lose some signal. So I was wondering whether maybe EKG triggering has to be very precise, whether you have to be really looking at basically a static window or quiescent phase, very well-defined quiescent phase for the myocardium to really show.
So for the non-cardiac part of the scan, it doesn't matter. So I think I showed a number of images where you can see the entire chest and lungs very nicely. Doesn't matter what phase of the cardiac cycle, it's very robust. If you're imaging the heart, then yes, you do want to image in a static part, and that's where we use the PSIF version rather than the FIS version. And that works well, but you do have to image in a static portion of the cardiac cycle.
Thanks.
That is really amazing how they just light up, and it's so easy.
Yeah.
Can you perhaps comment a little bit of the spectrum of lung diseases? You showed mostly, I think, cancer in the lungs, but could you comment on the spectrum? Would cystic fibrosis also work?
Right,
Would
right,
this also
so-
work at lower field strength, etc.?
Yes. So, well, I can't comment on lower field strengths. We've used 1.5 and 3 tests. It works well at both field strengths. Again, because it's not sensitive to off-resonance effects, 3T works fine. Haven't tried it at 0.55, although there are individuals starting to do that. We've used it in other types of pathology, but for time reasons I didn't show it. Sarcoid, heart failure, just to see edema in the lungs. I think it could be quite useful, and you can also change the contrast by applying T2 preparations and so forth. So that remains to be explored.
Thank you. Okay, we move on to the next lecture, next talk. Validation of respiration resolve 5D flow MRI with real-time 2D phase contrast MRI and respiratory bellows. Thank you.
Thank you. Unfortunately, Elizabeth was not able to be here as she just finished her PhD and is back to med school, so I will be giving the talk. I'm Justin Baraboo. I have nothing to disclose. So I want to start off by talking about breathing and MRI, especially from a flow perspective. So what happens when we breathe is we have a pressure change in the chest as we go from expiration to inspiration. Now, if you ask a cardiologist what happens when we breathe, they may say we have differences in blood flow due to this, where our stroke volumes change across the respiratory cycle, and we can see larger changes in the cable veins. However, when it comes to MRI, most of what we look at for breathing is motion related, as it corrupts our images, and we want to stop that quite literally, because we'll do things like breath holds, where we see one part of the respiratory cycle. Our respiratory navigators for this as well. We may want to scan fast and use things like free breathing acquisitions, which sort of average this all together. And what was sort of alluded to by Dr. Schnell and Dr. Lieben earlier this week is the use of 5D flow MRI to resolve the respiratory dimension and assess the blood flow across the respiratory cycle. So 5D flow MRI, we can think of it as just 3D velocities, so we're able to measure blood flow in a volume across a reconstructed cardiac cycle, but now we have a respiratory phase added onto that, so we can see how the blood flow changes from expiration to inspiration. Matthias actually went over this quite a bit of how this is able to work, and it's really due to compressed sensing and 3D radial sampling, as the compressed sensing allows us to reconstruct highly accelerated data, and the radial sampling allows us immense flexibility in our reconstruction, where we can take our total acquired K-space data and have immense flexibility to resort it any way we want. Apply that to our compressed sensing algorithm and get out flow information associated with this. So if we sort it alongside the cardiac signal and the respiratory signal, we'll get gating in both of those dimensions. So what this looks like is we'll do a fixed scan time for roughly 9 minutes. We'll follow this radial trajectory. What happens is we start with an SI projection in order to do self-gating, and we follow up with 5 blocks of 4-point velocity encoding in order to get our blood flow information. So while this 9 minutes was happening, the patient's heart was beating, and they were breathing, and we're able to extract this with self-gating. We can then take these signals and subdivide them to different frames where we can do basically retrospective cardiac and respiratory gating, and then use the above reconstruction in order to get the information. And we get a 5D flow data set where we can interrogate the flow not only across the cardiac cycle, but also with respiration. So Elizabeth has been utilizing this really to show its use case in congenital heart disease, where I'm going to show Juan Fontaine case today, which is a single ventricle disorder where they attach the inferior and superior vena cava to the MPA, and this is sort of what it looks like for flow imaging, where this is 5D flow and I'm only showing inspiration. But I can show it for the entire respiratory cycle as well, which we can see here. And I want to look really at the IVC net flows, and you can see that they change quite dramatically as we go across the respiratory cycle. And in particular, if we look at the end expiration and inspiration, which we may do for breath holding or navigator gating, we can see there's quite a stark difference between them, and what alone will not give you enough information to really truly understand what's happening. So this is great, so the idea is that breathing is important and may impact our blood flow, and we can use 5D flow to resolve the respiratory dimension, and this may be particularly important in congenital heart disease. However, the self-gated respiration flow has not been systematically validated against an independent reference standard, so we may be putting the cart in front of the horse. So what Elizabeth really wanted to do was to validate the signal extraction, where we take the self-gated respiratory signal and compare it to the respiratory bellows. Then we also wanted to compare the blood flow validation, where we take the 5D flow and compare it to 2D real-time phase contrast MRI. So for our methods, we took 10 healthy volunteers and we put them in an MRI with the respiratory bellow attached to them. And we performed 5D flow and 2D real-time phase contrast with acquisition parameters shown here. We really tried to match the temporal resolution and the VANC together, but we do note that there is quite a big slice for the 2D real-time phase contrast, and the reconstruction techniques are different. So the way that we validated this is for our signal comparisons for respiration. We performed cross-correlation to align the two signals together and reported the average time delay and the correlation between them. For the flow quantifications, we used Circle to analyze both the 5D flow and 2D real-time phase contrast, where we placed planes in the aorta, main pulmonary artery, superior vena cava, and inferior vena cava shown here. And then for the flow quantification, we looked at net flow and median flow, where these were all normalized to end expiration across the respiratory cycle, as we wanted to see the impact from that alone. Then the other thing we quantified was the relative change in net flow by looking at the range across the respiratory cycle divided by the mean in each of these vessels between the two techniques. So real-time 2D phase contrast allows us to find through plane velocities, and we acquired this for 38 seconds, which means we get 38 seconds worth of heartbeats to be reconstructed, which gives us a flow time curve that looks like this. So then using the ECG, we're able to delineate the heartbeats and put them together, and then using the respiratory bellow gating, we're able to figure out which part of the respiratory cycle they came from and apply it similar to the 5D flow sort of retrospective gating. So for now, for expiration and inspiration along the respiratory cycle, we can now compare directly the 5D flow and real-time 2D phase contrast at each of these locations. So here are our first results for the self-gating with the respiratory bellows, and this is our best case, where you can see there is good alignment between the bellows and the self-gating signal, and they agree pretty well. Here's our worst case, where you can see there's actually quite a big of shift in the red between the self-gating and the bellows when you look at this, but I want to draw your attention specifically to these sort of dotted boxes. As in the self-gating signal, we would often see sort of these points where it looked like the patient was either holding their breath or doing shallow breathing, but could have also been an artifact from the extraction of the self-gating signal. But we saw this also in the bellows, which really helped to validate that this is a real phenomenon. So overall, the correlation was actually really strong between the two signals of 0.71, and the average time delay was roughly 0, but had a high variation, so the signals either shifted before or after, or compared to the self-gating. Finally, we then have results that the 5D flow MRI agrees well with the 2D real-time phase contrast. So if we look at the relative net flow changes between the two techniques, there was a moderate correlation of 0.64 between them, where I'm showing here for the 4 different vessels that we looked at for the aorta, MPA, IVC, and SVC. And then if we look at the median net flow curves that again were normalized to end expiration to really see the effect of respiration itself, there was no significant differences between the two techniques of the 5D flow and real-time phase contrast. between them except for at the end expiration of the main pulmonary artery. So they didn't show major disagreements between them. So to conclude, 5D flow allows us to quantify 3D respiratory result hemodynamics, and the self-gating signal in this study was really what was validated, where we were able to see that there was a good correlation between it and the external reference standard of the respiratory bellows. And then when we looked at the flow, there was a good agreement between 2D real-time phase contrast and 5D flow across the different respiratory cycle. The limitations for this study is that it was a fairly small sample size of just 10 patients, and none of these are really a true gold standard, but it was nice to see that they correlated as different standards. And so with that, I would like to thank my collaborators and you for listening. Thank you.
Thank you. Any question? Very interesting lecture. I have a question regarding patient. Have you tried in patient?
So we've used the 5D flow extensively in a lot of pediatric patients, where we've seen differences between the respiratory cycle in the cable veins. And Elizabeth recently presented at ICMRM that investigating like how many bends you need, as we always do 4, but she showed that it's actually can be quite flexible and just do 2 or 3 and still see differences between them. I don't think we saw so many differences here in the healthy controls, as they have less of an effect of the respiratory cycle on that than if you have congenital heart disease and really like the cable veins really being affected by the breathing.
More specifically in patients with Fontan procedure, yeah, you've tried?
Yes, and we've shown that there is respiratory-driven differences between the different states.
Just have a quick question about that Fontan case. It looked like all the flow from the left pulmonary artery was going to the right. Is that really the case? Did that change with respiration?
Yeah, so this was a very unique case that I didn't have too much time to get into, but they have a massive collateral system that was causing the right pulmonary artery flow to shunt into the left pulmonary artery.
Great, thank you very much for that excellent presentation. We'll move on to the next talk, which will be given by Dr. Pauline Gutt, titled Improved Myocardial Scar Visualization in Patients with Cardiac Implantable Devices.
Thank you. Hello everyone, so my name is Pauline Gutt. Let's talk about how we can improve scar visualization in patients with a cardiac implant. I have nothing to declare. More than 1 million of cardiac devices are implanted in patients every year worldwide, and up to 75% of those patients will require a cardiac MRI post-implantation. The problem is when you want to do a cardiac MRI for a patient with a cardiac device, there will be some local field inhomogeneities, since it's a metallic device, that will result in signal void, hyperintensity, and ripple artifacts on the images when you use a conventional phase-sensitive inversion recovery, PSIR, lead gadolinium enhancement imaging technique. A few years ago, wideband PSIR MRI has been developed in order to reduce the artifacts related to the devices by broadening the spectral bandwidth of the inversion pulse in the PSIR technique. However, PSIR provides a poor contrast at the scar-blood interface that can result in scar ambiguity, especially for subendocardial scars. Black blood imaging has been developed in order to improve the scar detection by simultaneously darkening both the blood and the healthy myocardium signals. The aim of my project was then to combine black blood LGE with wideband MRI in order to reduce the artifacts related to the cardiac device while improving the scar detection. For this, I implemented the sequence on a 1.5 Tesla. It was a 2D breath-hold, single-shot ECG-triggered gradient echo readout. It consisted of an inversion pulse followed by an adiabatic T2 preparation. And the wideband technique was implemented in the inversion pulse as well as in the 2 refocusing pulses of the T2 prep module by broadening their spectral bandwidth. The method was tested on an animal, a sheep, who had a myocardial infarction induced by embolization, MRI was conducted with and without an ICD, a defibrillator. In case of ICD, it was taped on the side of the sheep near the shoulder. And we applied 4 different sequences. So we had our reference PSIR, standard and wideband, and then we applied standard black blood and wideband black blood. We also applied the technique for patients with known scar tissue and with ICD. For them, we applied the reference standard PSIR as well as standard black blood and wideband black blood. A radiologist scored the image quality and artifact severity, and we also analyzed contrast ratio in the animal only. Let's start with the animal results. So here we first start without ICD. So you can see the standard PSIR LG image. We can see the scar tissue, but we have some scar ambiguity shown with the red arrow. Using black blood LG, we were able to improve the scar detection very nicely in the animal. And for the wideband technique, so here it's the case without ICD, we got similar results to the respective standard techniques. Now, in case of ICD, so when it was taped on the side of the sheep, we had some artifacts from the ICD near the myocardium using standard PSIR LGE that were reduced using wideband PSIR. In case of standard black blood, the images were severely degraded by hyperintensity artifacts shown with the green arrow that were successfully suppressed using wideband black blood LGE while improving the scar detection. Now for the contrast ratio, so it was analyzed on the images without ICD. The hatched column represents the black blood technique. The scar myocardium contrast ratio was slightly better using black blood LG compared to PSIR. Scar blood contrast ratio for standard black blood were also improved compared to PSIR. And finally, contrast ratio of blood myocardium using black blood were decreased compared to PSIR due to the simultaneous darkening of blood and myocardium signals. We also have the results for wideband techniques, and we can see that the contrast ratio are constantly reduced compared to the respective standard techniques. Now, for the image quality and artifact severity, still in the case without ICD, we had very high score for standard PSIR and standard black blood LGE, and using wideband, we had exactly the same results as in the standard case. Black blood LGE was able to identify more scar segments than PSIR LGE. Now, in the case with ICD, so the yellow bar, if we use a standard PSIR or standard black blood LGE, we have the decreased score due to the presence of ICD. We also realized that standard black blood images were more affected than standard PSIR images. And then using wideband PSIR and wideband black blood, we were able to recover the scores of standard PSIR and standard black blood LGE without ICD. Now for patient results, so at the top you can see standard PSIR that were highly affected by hyperintensity and ripple artifacts. We can see nevertheless a scar tissue, but there might be a scar tissue that can be hidden with the artifacts. Standard black blood was also affected by hyperintensity artifacts that were reduced or even suppressed using black blood imaging. This patient had a subcutaneous ICD. The results for the 3 other patients who had a transvenous ICD were similar. So all the images using standard PSIR and standard black blood were severely degraded by the presence of ICD, so with hyperintensity and ripple artifacts. And using wideband, we were able to suppress those artifacts while improving very nicely the scar tissues. Finally, for the image quality and artifact severity scores, using standard PSIR and standard black blood, we had quite low score due to the presence of ICD. Nevertheless, standard black blood was already able to identify more scar segments than standard PSIR. And for wideband black blood, we were able to improve the image quality and artifact severity scores, as well as the scar segment detection. In conclusion, we showed that wideband black blood algae is able to suppress the hyperintensity and ripple artifacts due to the presence of ICD while improving very nicely the scar detection. From the animal study, we could also show that we can get similar image quality and artifact severity scores than in the case than reference PSIR without an ICD. As an outlook, so in the future, we could combine this technique with bright blood algae in order to improve the anatomical information that we may lack with black blood images. This could improve the clinical decision making for treatment. And an interesting application would be to extend in 3D in order to model scar tissue and facilitate catheter ablation. With that, I would like to thank all the collaborators and my team both in Lausanne and in Bordeaux, and thank you for your attention.
Thank you very much for this very nice presentation. Any question? Yeah.
Yeah, just very nice work, just beautiful images. Just a quick question regarding the RF energy deposition. So you're now including the wideband inversion and then the wideband T2 prep. Of course, you're only applying them once per cardiac cycle. It's probably okay, but did you measure the B1 plus RMS or SAR or something like that to see, how hot are these collection of pulses?
Mm-hmm. So I did not analyze the SAR with, we didn't do a proper analysis. However, we never had any issue with the SAR. But now if you go to 3D, maybe this will be problematic. So this is something that maybe we have to work on it. But for 2D, it was not a problem.
Okay, great.
Thank
Thanks.
you.
Other question? Thank you. Very, very nice. Thank you. Let's move on.
Okay, the next presentation will be given by Dr. Yu-Yang Ren, entitled Rapid Reconstruction for Accelerated 4D Flow MRI Using a Deep Low-Rank plus Sparse Network.
Thank you for the introduction. Hello everyone, my name is Yu Yang Ren, a master student from Shanghai Tech University. Today I will introduce our work, Rapid Reconstruction for Accelerated 44 MRI using a deep low-rank plus sparse network. I have nothing to disclose. 44 MRI is well known for providing hemodynamic information, but has a long acquisition time. To overcome such limitation, we seek to find a fast and accurate recount method for highly accelerated 44 MRI. Here, our method focuses on solving the following low-rank plus sparse optimization problem, which holds that the 44 data can be represented as a low-rank component plus a sparse component. And this problem can be decomposed to 3 subproblems. For low-rank subproblem, the singular value thresholding is applied. For sparse subproblem, convolutional neural network was used to directly give an approximate solution. We use a total of 744 data of ELTA provided in the paper of flow variational network, 6 of which were used for leave-out cross validation and 1 for test. During network training, the whole 44 data was cropped in the temporal and frequency encoding direction, and 1 plus 3D convolutions was used to reduce memory consumption. And the acceleration factors varies from 8 to 20 times using a variable density sampling mask. This is one example of the reconstruction of the test data produced by CS-based local low-rank flow variational network and flow L plus SNet. It can be found that our used flow L plus SNet shows the lowest error and the shortest recount time. This is a general overview of the results. Our method has the lowest error on both cross-validation set and test set in different acceleration factors compared with CS-based local low-rank and flow variational network. So the conclusion is the flow L plus SNet has the potential to reconstruct 44 MRI with higher acceleration factors. In future, more retrospective and prospective validation experiments will be carried out. That's all. Thank you.
Okay, Thank you very much. We will now move on to the next power pitch given by Dr. Zhu, entitled Subtractionless Compressed Sensing Accelerated Whole Body MR Angiography Using Single Pass Half Reduced Contrast Dose Feasibility Study.
Okay, thank you, John. So the author couldn't come here to the conference, so I will help him present his work. His name is Xiang Chuangkong, and he's from Wuhan Union Hospital in China. So this work is about whole body MRI, and for the conventional method, typically it requires using 2 sets of scans and 2 contrast injections. However, this is subtraction-based method, and which is very sensitive to patient motion. So they proposed a method which is based on M-Dixon because this has better SNR and also do fast suppression. And then they also combine with the compressed sensing method to accelerate the acquisition. So this method is like single pass, half dose, and no subtraction. And they have 2 groups of patients recruited to evaluate these 2 methods. And here is the MRI exam. It was performed on a 3T Philips scanner, and it covered 5 stations of the patient. And here is the workflow of the 2 methods. So on top is the conventional whole body MRI. You can see that it requires 2 contrast injection, and the bottom is a compressed sensing based M-Dixon method, which is only single injection, cover all 5 stations. And to evaluate, they have done both qualitative and quantitative methods. So for the qualitative methods, the results show that overall score of the compressed sensing based whole body MRI outperformed the standard whole body MRI. And also for the quantitative study, is that there's no significant difference between these 2 methods. And also they also compared the venous contamination in different segments. And also the proposed method is much better. And exam time is reduced, and of course it's half dose. And here shows the image comparison between these 2 methods. So on the left is the conventional method because it's subtraction based, you can see the contamination. But on the right side it's single acquisition, so it's much clearer. And they also show 2 examples, clinical examples. So this one has multiple stenosis, and this is second example. So in conclusion, so this proposed CS-based whole body MRI offers fast workflow and less sensitive to motion, and it's only single pass. They have recently published this paper on the JCMR, so if you have interest, you can take a look. Thank you.
Thank you. We will move on to the next presentation, presented by Dr. Mitsui Miyazaki, entitled Popliteal Artery FBI Using Centric KYKZ Trajectory and Exponential Refocusing Flip Angles for Minimizing Saturation Effects.
Thank you. So in FBI, or fresh blood imaging using the systolic and diastolic acquisition and subtraction using a physiological difference in those 2 cases. To increase the scan time or decrease the scan time, we use the centric KYKZ and applied a different variable flip angle to reduce the saturation effect. We studied the simulation of the blood signal. And this is the center of case space. You need a high flip angle, and lowering the flip angle to reduce the SAR in addition to the saturation effect. So you can see here the conventional constant flip angle by reducing the lower flip angle, returning a T1 recovery to gain the signal. So we studied a different flip angle in the lower flip angle. So here is 90 degree, 60, 30 degree, 18, and 2 degree, and we measure the signal intensity on the upper side and the lower side. And you can see that the constant ratio as well as signal to noise ratio show the increased signal intensity in using the lower flip angle. However, because of sensitivity of these two acquisition, there are residual signal remain in the background. So we decide to use the lower flip angle. So still we gain the signal intensity even in the lower portion. And the two technique was acquired with the standard and as well as the centric KYKZ FPI. The score was a little bit better with the centric KYKZ. However, that scan time is about the half. So gaining the, this is example. Here's the N/2 artifact in standard FPI, and compared to centric KYKZ, does not show any N/2 artifact, as well as the motion artifact has been reduced. It could be because of the shorter scan time, maybe motion less sensitive to motion. In conclusion, centric KYKZ FPI acquired less scan time, about a half, and lowering flip angle bring the signal intensity for the faster recovery and reduce the artifact. Thank you so much for your attention.
Thank you. We will move on to the next power pitch, which will be given by Dr. Sean McGarry, entitled Translation of Vessel Metrics from Confocal Microscopy to MR Angiography Data.
All right. I work jointly with a developmental biology lab and a human imaging lab. Over the last 2 years, I've spent the majority of my time creating a Python-based software library to analyze vessel morphology and confocal microscopy. This talk is a pilot study translating from confocal microscopy to MR angiography data. VesselMetrics is an open source Python-based software library which analyzes vessel morphology analysis end to end. We take a confocal microscopy image and create a maximum intensity projection. We pre-process the image to homogenize the contrast within the vessel, and then we're able to enhance the vessel and set a threshold in order to segment the vessel structure from the background. From there, I can skeletonize the vessel to create individually labeled segments as well as branch points to do a parameter analysis across the entire vascular structure. We're also able to fully automatically measure diameter on these vessel segments. I have validated this study in 2 different stages of development in fish, in mice, and in experimental fish using 3 different microscopy modalities. We went into this pilot study today with 2 primary questions. Can we get this to work in time of flight data, and can it be used to answer any interesting questions? So my segmentation technique had to change slightly in order to get it to work with the time of flight data. I'm still using an intensity projection here, but we'll be hoping in the future to be able to do this on a slice-by-slice basis. My background suppression needed to change because the time of flight data tends to already have homogeneous contrast within the vessels, but it has a much brighter and more intense background signal. So there's a local and non-local means background suppression, followed by a vessel enhancement and a thresholding. The metrics that you're seeing at the bottom of the slide here are Jacquard indices. These all correlate to a DICE score of about 0.8. We've split this into 3 different groups: young, healthy participants, elderly healthy participants, and patients who have clinically confirmed SVD. Interestingly, our segmentation output here roughly matches the metrics in confocal as well as our mouse data. I did an experiment to test whether my diameter measurement would be accurate in the time of flight data as well. I did this on the MCA and the PCA, 2 segments per patient, over 27 patients, so a total of 54 vessel segments here. And we found that we're actually a little bit more accurate than we were in the confocal data. My goal here was to be within 1 pixel or voxel boundary on either side of the vessel, and we've managed to hit this metric. I tested a number of different parameters to see if we could make any conclusions about different vascular structure over the course of aging and in disease. This was quantified via an ANOVA, and we didn't see any differences across any of the parameters here. Network length is the sum of all of the vessel center lines, and I also cropped that into the circle of Willis as well. This could either be because there's no measurable effect, or because the individual patient variance is larger than the effect size that I'm trying to measure. In conclusion, I've successfully translated my software from confocal microscopy into time of flight data. I need to do more future studies in order to determine if I can make this do anything interesting and make any conclusions about small vessel disease in humans. Thank you for your time.
Thank you so much. We will now move on to the next power pitch given by Dr. Hao-Kun Lee. The talk is titled Convolutional Recurrent Neural Networks with Diffusion Model-Based Refinement for Cardiac Cine MRI Reconstruction.
Thank you very much for your introduction. I'm Hao-Kun Lee from Center for Biomedical Imaging Research, Tsinghua University, and it's a great honor for me to present here. I have nothing to disclose. Nowadays, Cine MRI has been widely used in clinical medicine, but its long acquisition time has always been a major drawback, which may cause patient discomfort and more severe artifacts. One major way to mitigate this problem is to perform undersampling during data acquisition stage. However, traditional reconstruction methods are often unsatisfactory, and supervised learning-based methods have their respective problems. CRNN always reconstructs fine structure with blurred details, while generative models often produce fake structure. Hence, we came up with the idea to combine CRNN with generative model to achieve both structure fidelity and clear details. Our method used a kind of new and powerful generative model, the diffusion model, to refine the coarse results constructed by the CRNN. The main innovation of this work is the network structure designed for dynamic MRI reconstruction. We use a U-Net-like structure with noisy image in the diffusion process concatenated with the CRNN coarse result at this frame as main input, and the last and first refined frame as the temporal guidance. We use an innovative multi-scale feature extraction and fusion block to extract guidance information, concatenate the information into the main network. This structure effectively extracts the temporal constraints of the past frames and guides the main reconstruction network at different scales, ensuring the temporal consistency of refined reconstruction result. The training and inference processes are similar to CRNN diffusion model, and the details can be seen on my poster. All experiments were conducted on ACDC Cine MRI dataset. As for the numerical results, we can see that our results outperform the U-Net and diffusion model, but is slightly inferior to CRNN. This is probably due to the preference of the metrics towards overly smooth images. And on the single frame results, we can see that at the positions of red arrows, our model reconstructed clear borders, while U-Net and CRNN are blurred. And in the temporal results, the myocardial region was blurred on results of U-Net and CRNN, but it was rather clear on the results of the proposed method. I would like to thank the members of Center for Biomedical Imaging Research and the Society of Magnetic Resonance Angiography. That's all. Thank you very much for your attention.
Thank you very much. We will now move on to the last power pitch of the session, given by Dr. Stephen Reeder, and the title is High Density Receiver Coils for Improved SNR in Pelvic MRI.
Thank you. Today I want to talk about receiver coil technologies used for pelvic MRI and MRA. About 10 years ago, air coil technology was developed, and a major advantage of these coils was the very flexible mechanical flexibility. These are less than 1 millimeter in diameter and can be configured in many ways compared to traditional copper-based coils on a substrate. Now, the purpose of this talk, or the area of study of this talk, is to look at another major technical advantage of these air coils, and that's low mutual inductance, which affects the crosstalk between coil elements. Now, traditional copper-based coils have an overlap of about 25% based on mutual inductance. If the overlap changes, the net signal from the coils will deteriorate. So we asked the question, can we use this to advantage with increased coil density with arrays of air coils? This shows a standard air coil layout with product arrays. There's about a 20% overlap of the coil elements. We took these same elements and overlapped them here. You can see it's almost a 50% overlap coil to coil. So in the central portion of the array here, there's much higher coil density and conceivably better signal to noise. So that was the study or purpose of this work. This shows a comparison, or what we use for a compare, an anterior blanket array from the product vendor and a posterior in-table array. This is used standardly for our practice. With our new air coils, with high density arrays, we have an anterior and posterior arrays. And the number of active elements is actually is 41 here compared to typically 25 to 30 with the conventional arrays. We did experiments in vivo on 10 men for whom prostate MRI was clinically indicated. We used a high slice resolution T2 spin echo acquisition. Parameters are shown here. The sequence was repeated once with each coil set, and the results were compared. Comparisons were done by 3 uroradiologists. No additional noise reduction methods were done for the comparison. And they did this on a 5-point scale, where the middle score meant that the 2 coils had equivalent perceived SNR or sharpness, and we allowed negative and positive scores from there. This shows the results. For signal to noise within the prostate, again, a neutral score 0 would mean equivalent performance. And you can see here that all scores rated the new coil superior in performance. The 3 radiologists are indicated by different colors. For SNR outside the prostate, similar. And as a consequence of the improved SNR, there can be an improved perception of sharpness of structures both within the prostate and structures affecting the prostate wall, rectal wall, seminal vesicles. Here's some sample images. The original array result on the left, the high density array on the right. You can see there's a little bit better definition of the nodular edge here, which is going to be important for detection. Here's another case. This is a large nodule, which would be confirmed actually with a diffusion weighted scan. There's improved signal to noise here on the right image equated with a high density array. Now, when the same data sets are sent to deep learning reconstruction, we get improved SNR for both, but still the quality is superior with the high density array. So in conclusion, air coil elements can be configured at a high overlap in not just 1 but 2 dimensions, and we expect to extend this to other anatomic regions. Thank you.
Great. Thank you very much for an excellent presentation. I believe we're at the end of the session, so I'd like to thank all the speakers for their excellent talks. Maybe we can give them a round of applause collectively.